Good evening, all. Today we'll discuss about how to approach a child with recurrent URTIs. So, let's Good evening, all. Today we'll discuss about how to approach a child with recurrent URTI. Why URTIs are common in children when compared to adults? Hello. Hello.
Because of immunity.
Okay. Yes. URTIs are more common in children than adults because comparatively the immune system is premature than adults. So children are more prone to URTIs. So does all the recurrent URTIs are complicated or normal? So we know URTIs are common in children. They are prone to bouts of URTI. So are these common or complicated? How to know?
Based on the frequency, how frequent the child is having the symptoms and how severe the child is having the symptoms.
Okay. So recurrent URTIs are common in children, but not all of them are complicated. So we should know like where child needs further evaluation. We should know where we should look more into that child. So very few studies and data is available on how to approach a child with recurrent URTA. So with the limited available data, today we'll try to learn a simplified approach to recurrent URTIs. So this is going to be a case-based discussion. So let's go to the first case scenario. Here is a 4-year-old male child with complaints of cold and cough since 3 days and fever since 2 days. So there is history of similar episodes of URTI twice in the last 4 months. So child was joined to school 4 months back. So on examination,
Board madam will come.
On examination, there is congestion, discharge, and child is febrile, but throat examination is normal and chest is clear. So what is the definition of recurrent URTI in children? So there is no established definition for recurrent URTI, but we know there are definitions for recurrent infections in specific areas like recurrent otitis media, recurrent pharyngitis, recurrent rhinosinusitis. So when we call it is recurrent otitis media, hello. So more than 3 episodes of otitis media in 6 months or more than 4 episodes in 1 year, it is considered as recurrent otitis media. Similarly, more than 5 episodes of rhinitis is defined as recurrent rhinosinusitis is defined as recurrent rhinosinusitis. Similarly, more than 3 episodes of pharyngitis or tonsillitis is defined as recurrent pharyngitis or recurrent pharyngeal tonsillitis. So, based on this data, for polytopic infections, Indian expert consensus in 2017 gave a definition for recurrent URTIs. It is defined as 3 or more episodes of URTIs in 6 months or 6 to 8 URTIs in 1 year. Why 6 to 8? Why there is a range? Why it is not 6 or 8? So it is again based on the age. For children less than 3 years, more than 8 URTIs in 1 year is considered as recurrent URTI. And for children more than 3 years, more than 6 episodes of URTI in 1 year is considered as recurrent URTI. So how to approach a child with recurrent URTI? How do you know whether it is normal or abnormal? How will you know whether the child needs further workup or not? So for any approach,
Number of episodes, ma'am. Severity of episodes.
anything else? So severity of episodes is yes important. Number of episodes, as we already defined URTIs, recurrent URTIs. So now we want to know which recurrent URTIs requires further evaluation, which needs more.
Associated symptoms and other system involvement.
Yes. So for any approach, like it should be schematic. So this is a more practical approach. So first, always comes your clinical examination. So that is your history and examination. So what history you will ask for recurrent URTIs, or what clinical findings you will search for while examining child with recurrent URTI? So to know that, you should know what is the etiology of recurrent URTIs. So these are the common conditions associated with recurrent URTIs. We can divide them into immunological and non-immunological causes. So in immunological causes comes your atopy and allergies, and immunological causes also includes your immunodeficiencies. And in non-immunological causes comes your ciliary defects, ineffective clearance of mucus, any cardiovascular abnormalities, micronutrient deficiencies, social causes like early schooling, and environmental causes like passive smoking, indoor air pollution, etc. So if you know the etiology, accordingly we can ask for required history, and also we can see for findings. So let's go back to the algorithm. So any patient coming to you with a history of recurrent URTI history. So what history will ask? So anyway, in present history, we will ask about the onset of duration of symptoms and all. So what you will ask in past history?
Was there any frequent episodes in the past with a similar complaints?
You can ask for number of similar episodes in the past 6 months, past 1 year, and we can also ask about age of onset of first episode. This is important for allergic rhinitis and immunological conditions. And in birth history, and we should ask about any preterm deliveries, any history of ventilation, etc. we should ask. Similarly, in family history, you should ask for any family history of allergy, atopy, and any family history of recurrent infections we can ask. And what else is important in history?
Any other system involvement?
Yes, any other sites of infection, any other systemic involvement. The vaccination history, is it important?
Yes, ma'am.
Yes, ma'am.
Yes, vaccination history. And social factors like at what age child started going to school. Does the child was put in daycare centers from the beginning? Like that. So history is very important. Then comes your clinical examination. So in your clinical examination, your like thorough examination of ear, nose, throat, and any systemic causes like any cardiovascular problems of cardiovascular system like congenital heart diseases, we should look for in systemic examination. And what else we look in examination?
Any signs of malnutrition? And
Exactly. So growth is very important because it will give you a clue whether the child is that recurrent URTI is a normal or abnormal for that child. So you should take a proper like plot a proper growth charts. Growth is so, and also we should look for what if you are suspecting any ciliary dyskinesias or any cystic fibrosis, what findings you look for? Definitely child will have like failure to thrive, like he will be you should plot a growth chart, and he can also have clubbing. So you should so clear-cut clinical examination will hint you towards the diagnosis. Next comes your evaluation of the underlying disease. So this includes like if you are suspecting a cardiovascular disease, then you can evaluate the child for like congenital heart diseases with echo. And if you are suspecting GERD, evaluation for GERD. And if you are suspecting any allergies, you can go for allergen testing. And lab investigations are indicated only if the child is toxic. If he needs hospitalization, like if you are suspecting any, like child is too sick, if you want to know whether child is in sepsis, then chest X-ray lab investigations are indicated. So then if the child is having some DNS or like any anatomical problems, you need an ENT referral. So allergist, when you will refer a child to an allergist, if the child is having severe symptoms, severe symptoms, not you are not able to manage the child with your pharmacotherapy, your medication, then you can refer the child to the allergist. And if you are suspecting any immunological primary immunodeficiencies, you can refer to immunologist. So following a schematic approach, like always proper history and clinical examination always drive you towards a proper diagnosis. So let's go to the case scenario. So this child, there is no history of allergy or atopy and no history of hospital admissions, and height and weight are normal for age, no other significant examination findings. So what is the diagnosis in this child and how will you manage this child? So this is definitely a child with a recurrent URTA. And what is the cause you found in this child? So there are any red flags in this child, and this child is a recurrent child with recurrent URDA, and this child has been recently joined to school. So there is a term called daycare syndrome, where the children are prone to recurrent URTAs who are like recently joined to school. So this recurrent URTA probably looks because of the child joining the school recently, and also due to, as we discussed earlier, because of prematurity of the immune system. So how will you manage this child?
ma'am, probably viral. So we will manage with anti-inflammatory medication and saline nasal spray. And if fever is there, paracetamol SOS.
Is there any role of antibiotics here?
Ma'am, depend on the condition of the child, how severe we are feeling the infection is. Is the child active between the fever or not? If how clinically child is presenting, pointing towards bacterial infection more or viral. If pointing more towards viral infection, then no need. We can wait, ma'am. If not, then we can start antibiotic.
So what are the pointings favoring your bacterial infection? Like, are there any indications to start antibiotics in URTIs? Yes, child looking sick in the interfebrile period. Yes, it hints towards your bacterial infection. So, are there any indications? Yes, dull activity. These are the red flags for starting antibiotics in URTAs. That is, if the child is having toxic presentation, like you guys already telling, and high grade fever, any purulent pharyngitis or purulent discharge, or the child is having any respiratory distress, and you are suspecting the child may land up in LRTA, and if there is no improvement with your symptomatic medication, and if there is any increased CRP. So what is the choice of antibiotics? Usually, what antibiotics you will prescribe for URTIs?
Amoxicillin, penicillin group of drugs.
Penicillin group
Or
of drugs.
azithromycin.
In very younger children, we will prefer amoxicillin, and if the school going children and all, we usually prescribe azithromycin, and ceftriaxone is another alternative to amoxicillin. So coming to case scenario 2, there is a 5-year-old male child with history of cough since 10 days, increased in severity since last 3 days, which is more at night. And there is history of cold, fever since 3 days. Coming to when asked about the detailed history, mother is telling the child frequently suffers from cough, like cold and cough. And this type of history, like frequent episodes of URTA, is present since past 6 months. And mother also told the child sleeps with, like while sleeping, he has mouth breathing. And even sometimes at daytime also, she observed child is having mouth breathing. So on examination, and the mother also gave the history of atopy in this child. So on examination, there is an anatomical defect, that is DNS towards left side. We observe there is a bilateral inferior turbinate hypertrophy and cobblestoning of the posterior pharyngeal mucosa. So what is the diagnosis?
Allergic rhinosinusitis.
Yes, allergic rhinosinusitis. With the clear-cut history and findings, it is very evident that child is having allergic rhinosinusitis. So how do you manage a child with allergic rhinitis?
Ma'am, again, antihistamines we will start with.
Yes.
We will start with saline irrigation. If the symptoms of our prolonged period and with inferior turbinate hypertrophy, we will start with any momentous nasal sprays, ma'am.
Okay. So allergic rhinitis is in increasing incidence nowadays. So it is seen in more than 5 out of 10 children. So it is very important we should learn about allergic rhinitis. So always lines of management will include pharmacotherapy, allergen avoidance, and allergen immunotherapy. The allergen immunotherapy is the last resort for severe symptoms who are not responding to our pharmacotherapy. So we are not going to discuss about it now. We'll mainly concentrate on pharmacotherapy for allergic rhinitis. So as you guys already discussed, it is with antihistamines, local corticosteroid sprays, and saline nasal irrigation. So again, we can divide it into children less than 2 years and children more than 2 years. Any child presenting with signs and symptoms of allergic rhinitis and the child age is less than 2 years, always rule out other causes of recurrent URTIs. What are the causes of recurrent URTIs in children less than 2 years? Common causes.
Infection.
Is infection, and that already we discussed, earlier.
Allergy.
And another thing is allergic rhinitis.
Allergy.
We want to rule out common causes before allergic rhinitis. One can be your adenoid hypertrophy, and another can be your chronic rhinitis, chronic rhinosinusitis. So, in any child presenting with symptoms of allergic rhinitis less than 2 years, always rule out other causes. And after ruling out other causes, treatment includes oral antihistamines and saline nasal spray. How does saline nasal spray works? What is the rationale for why we are giving saline nasal spray? How it works?
It mechanically clears the airway, ma'am.
Okay. Okay. We'll discuss about it clearly in the next few slides. In any child presenting more than 2 years of age, for mild symptoms, we can give oral antihistamines. And if the child is having episodic symptoms, like the child is prone to episodic symptoms of allergic rhinitis, then we can try glucocorticoid nasal spray for a brief duration, like 1 week, 10 days. If the child is having persistent symptoms or moderate to severe symptoms, then we should start glucocorticoid nasal spray. What are the nasal sprays you know?
Mometasone, fluticasone.
Yes, mometasone and fluticasone are frequently used in nasal sprays. So glucocorticoid nasal spray are the recommended and the recommended single line therapies for allergic rhinitis. And there are few studies showing that for combination therapy like antihistamines and glucocorticoid nasal spray, there is no proven efficacy with the combination also. So glucocorticoid nasal spray are proven single line therapy for allergic rhinitis. So what is the dose of mometasone or fluticasone we'll give? Usually we'll say 1 spray in each nostril. So what is the role of montelukast acid in allergic rhinitis? Is it indicated in allergic rhinitis? How many of you are using montelukast acid as first line? Like you are starting it as first line in when you are suspecting allergic rhinitis? Hello? Hello?
Ma'am, audible, ma'am.
Yes. What is the role of montelukast acid?
Membrane stabilizer.
Yes, it's a mast cell stabilizer, leukotriene antagonist, and guidelines are recommending that and montelukast is as efficacious as any antihistamine. Like there is no proven efficacy of montelukast over antihistamines. It is as efficacious as like the efficacy of oral antihistamines and montelukast are same. And upon that, with montelukast, neuropsychiatric symptoms are more like anxiety, depression, like irritability. These are more with montelukast. So this is less recommended nowadays for allergic rhinitis. And about saline nasal irrigation, so it is recommended for allergic rhinitis or any other rhinitis. As already you guys told, it clears the nasal mucosa, it clears the allergens, and before giving any like you are giving mometasone spray or fluticasone spray. If you irrigate with a saline nasal spray, it clears the secretions and it helps your corticosteroid to act. So there is a level 1A level 1A evidence, and it is saline nasal spray and topical steroids are recommended for recurrent recurrent URTIs. And this is a Cochrane review done on saline nasal spray, and it shows that there is so in children presenting with the symptoms of sore throat, using a saline nasal spray has reduced the time of resolution of symptoms, and it also reduces the usage of other decongestant and antihistaminic medications, and it also reduced the number of symptoms, and it also reduced the duration of the symptoms. So coming to the next case scenario, there is a 6-year-old male child with history of fever, throat pain since 3 days, and decreased intake since night. Past history, there is one admission for pneumonia recently 1 month back, and mother also gives a history of recurrent URTIs and history of ASOM. And this child also had an episode of GE at 3 years of life, requiring prolonged period of admission. So on admission, the child is on examination, the child is toxic, febrile, he has tachypnea and throat congestion present with bilateral tonsillar hypertrophy, and exudate is seen on right tonsil. And on examination, chest is clear. So how to manage this child? So what is the diagnosis for this child?
Currently, child is on acute bacterial
Yes, acute probable bacterial tonsillopharyngitis.
pharyngitis.
How do you manage this child? Does this child needs admission? So what are the indications for admission?
If the child is not a toxic look with the not able to take orally.
Yes. Exactly. If the child is toxic, constant vomiting and dehydration, or if the child is having tachypnea and retractions, irritability and cyanosis, or if he is having persistent symptoms despite your oral medication and oral antibiotics, and if you feel the child requires IV antibiotics, or if there is any signs of upper airway obstruction, which is very important, any drooling of secretions, typical swallowing, stridor, it is a definite indication for hospitalization. So how do you manage this child? So we'll admit the child, start fluids, IV antibiotic. So treat the child on IP basis. So you are treating the child for this present infection. So does this child needs any further workup?
Yes, ma'am, we have to rule out for any primary immunodeficiency in this child. Because child had frequent episodes of fevers also involving lower respiratory tract and even GI requiring prolonged hospital stay.
Yes. Yes, definitely. So here is a beautiful algorithm to how to approach a child if he presents like this. So here in this end, they're discussing about recurrent URTIs, like recurrent infections in a specific area, like recurring pharyngotonsillitis, recurring otitis media, recurring pneumonia, and recurring sinusitis. Here we look into the local cause more and investigate and treat the child. And if the If the child is having polytopic respiratory infections, like we already discussed in the definition, like mixed respiratory infections like otitis media, pharyngotonsillitis, along with your pneumonia or lower respiratory tract infections, and here they define these definitions as per the age of the child, like up to 3 years, 3 to 6 years, and 6 to 12 years. And as per definition, if the child is falling into recurrent respiratory infections, so what do you rule out first? First thing is you should look, like again you will follow the schematic approach of like your history and clinical examination. So first you rule out the social causes, treatable causes, allergic rhinitis, and common treatable causes. If the child is having like if you rule out all the possible common causes like allergic conditions like daycare, recurrent URTIs, daycare syndromes. If you rule out anything like everything, next you should look for immunoglobulin levels and blood count. So for immunodeficiencies, we can't go for all the investigations at a time. We can go in a stepwise manner. If there is any decreased IgG levels or decreased response to like decreased antibody levels to vaccines, it suggests towards your prime immunodeficiencies. If these are not present and clinically, if the child is having failure to thrive and if the child is having clubbing and having history of diarrheas, we should suspect cystic fibrosis. Then during that, like such conditions, we will go for a sweat chloride test. If IgG levels are low or if antibody response to vaccines is low, then and if there is child is having any neutropenias or selective decrease in the cell lines, we can suspect immunodeficiencies. And similarly, coming to the extreme end, if the child has mixed infections, like how this child presented, like child is having chronic diarrhea or recurrent episodes of otitis media or recurrent atypical infections, or there is any family history of like similar family history or history of consanguinity, in such children also we should suspect immunodeficiency. And investigations should always go in a staged way, like which immunodeficiency you are suspecting, depending upon the age of the child, presentation, etc. But most commonly, bacterial infections are recurrent URTIs. Common conditions associated will be like your humoral immunodeficiencies, like decreased IgA, decreased IgG, or common variable immunodeficiencies, usually presents with the recurrent respiratory tract infections and pneumonias. And cellular immunities like are less common comparatively. Coming to the case scenario 4. So here is a 5-year-old male child with complaints of cough, cold since 4 days and fever since 2 days. This child is a known case of dextrocardia. So this child has history of frequent episodes of URTI and history of hospitalization for pneumonia. So on examination, this child has a height and weight is less than 3rd percentile, clubbing is present, nasal congestion present, and this child has fine thrusts with like. So what could be the diagnosis?
Carter-Jenner syndrome.
Why?
Ma'am, dextrocardia is there, suggestive of situs inversus.
Yes.
Then clubbing and chronic sinusitis, bronchitis, this kind of picture will be there.
Yes. Why this child has crepitations without tachypnea?
Bronchiectasis.
Bronchiectasis. So these children will have decreased clearance mechanism, so they can't clear the mucus like normal children. So because of that, they will have fine crepitations. But like it's a gradual process. So like so they don't have any symptoms of respiratory distress, like without any tachypnea, they'll have bilateral, like fine crepitations could be present in these children. So preventive strategies are very important for any condition, because we can cut it down at the like before onset only. So what preventive measures you will take to prevent recurrent URTIs in children?
Nutrition, ma'am.
Nutrition should be maintained, ma'am.
Yes, we can. Yes, okay. Okay. So for respiratory tract infections, we can follow social distancing, masking, uh, hand washing, active immunization, and prevention of environmental factors like passive smoking, indoor air pollution, and frequently cleaning the house, dusting the houses. So this is a table showing what are the preventive strategies we can make. So already discussed about immunization, and this is the role of supplements. And there are many studies suggesting that vitamin D and zinc can prevent recurrent respiratory tract infections. There is a proven role of vitamin D, zinc. Similarly, vitamin A, E, B complex vitamins, magnesium, these are also recommended in preventive strategies. So immunostimulants, it is still in the like studies are still going on. Even we don't there is no clear cut role. These immunostimulants are more commonly used in COPD patients, but in acute like recurrent URTIs still needs to be more studies has to come. And again, educating the parents and creating awareness among them. So what are the take-home messages? So recurrent URTIs can always not be normal, or can always not be seasonal or not uncomplicated. Sometimes we need to look into the other possibilities. It's like we'll know only if you go in a with proper clinical examination and history, we can find out which chain needs further evaluation and workup. So we should never miss immunodeficiencies. And similarly, defective airway clearances. These also we should try to pick up at an early age, so that we can give a better lifestyle for the child. And I also want to highlight about the role of glucocorticoid nasal spray and saline nasal spray. Glucocorticoid nasal spray is the only recommended single line therapy for your allergic rhinitis and allergic rhinosinusitis. And similarly, saline nasal spray. There are many studies recommending the use of saline nasal spray, and we already know the benefits of using saline nasal spray, how it works. And next comes here use of antibiotics. So for URTAs, sometimes based on the anxiety of the parents, when we are doubtful that child may again show up in the OP or not, we tend to use antibiotics more. So we need to use antibiotics judicially, because very few oral antibiotics are available, and we should prevent antibiotic resistance. And always and never least about the preventive measures. Yes, in preventive measures, someone told the flu vaccination is immunization. True, correct. hygiene, nutrition, vaccination, yes, all these are preventive measures. So any questions? Hello? So I'm closing the meeting. Any questions we can we can discuss in the group.